Good evening, everyone, and welcome on Sexual Health webinar. My name is Itzotot. I'm a cervical cancer survivor. I am the past co-chair of ENAGAGE and also the Quality of Life Series project lead. I am so glad that you have joined today. I was really waiting for this program so much. And whether you are here as a healthcare professional, educator, or patient advocate, your presence shows a real commitment to open, respectful, and informed conversation around this very important topic. So we really want to break the silence again in ENAGAGE and outside of ENAGAGE. And today's topic is the emotional side of sexual health and body image after gynecological cancers. So you can write your questions through the whole webinar to the question and answer box. Some will be answered in written format and some can be answered in the end, so speakers could discuss the questions, of course. Taboos only hold power as long as we remain silent. But once we find the courage to open the doors, we reclaim that power and step out of silence into action, like today. Together, we move closer to real change. We are able to be the key. ENAGAGE is the European network of gynecological cancer advocacy groups, and we belong to ESGO. And we have the Quality of Life Series project. And in this project, we have a lot of fields, of course, in quality of life. For example, for the soul, the To My Soul project, but we take care of menopause or lymphedema, nutrition, and of course, more will come. Gynecological cancers such as cervical, ovarian, endometrial, and the rare cancers like vulva and vagina cancers can significantly impact a woman's sense of identity, body image, fertility, and of course, the intimate relationship. We have a lot to do on this field. But what we have done, so first, of course, we asked the patients with ENAGAGE, which is young gynae oncologist, we had a survey and we asked the patient. From these results, we had several educational webinars for doctors and a little bit separately for patient advocacy groups about body, about soul, about, of course, devices and lubrication. We had also a separate ESGO ENAGAGE session in Rome this year when we had the ESGO conference. We have educational materials. You could see them in the waiting room and you can find them on ENAGAGE website. And ESGO guideline is coming, which is a very big success for ENAGAGE, of course. And today we are here and we approach this topic from the psychological aspect. And October, 8th of October, there will be the second part of the webinar. We will more take care of the physical part. So we will talk about, for example, surgeries, hormones, especially testosterone, and other important devices and examinations. So please, you can see here the QR code. You can find the registration. I know October seems far, but time is running, so you can have it in your calendar. Today, 8th of May, is Ovarian Cancer World Day. And because we really want to celebrate a little bit on ENAGAGE social media, you could see today a lot of posts, and not just on ENAGAGE social media, but in ENAGAGE, there are a lot of members, and we all celebrate World Ovarian Cancer Day. But regarding of this, we really wanted to approach this topic from the chronicle side as well. So Catherine will talk a little bit more about that one. So today we will have three presenters. Professor Dr. Katrin Kirchner, she will talk about the intimacy in the shadow of chronic illness and, of course, sexuality and quality of life in gynae cancer survivors. After Katrin, Stephanie will come saying the hard things, more about the conversations. And then we can hear about some real life cases from Dr. Toth. And then they have a discussion about the cases. And after there is a Q&A. But don't forget, please, that during the webinar, you can, of course, ask your question. So now let's imagine we are in a room, a warm, safe space where there's no need for shame, no need to perform, just to be in body and in soul. This room is ours now, a place to observe, to ask, to listen, and to share. Safety and the feeling of being safe must be present in every part of this topic, in body and in soul. Our destination, an inner space where we can feel safe. And to begin this journey, I would like to show you how the Mallow Flower Foundation in Hungary welcomes and supports people in this topic. When we were in Rome, I had a presentation and I was talking about our intimate boutique in Hungary. And after the presentation, some of you approached me and asked me about this intimate boutique. So we decided to make a video and show you this place. So seatbelts on. Okay, it seems I cannot hear the voice. I don't know, Katrin, if you can sign me back, if you can hear anything. No, good. Okay. I would like to ask our technical help.
Working on it, just a second, please.
Okay, thank you. So then we need a little patience. This room is difficult to approach, it seems so. I hope I can show you because we really shooted this video just for today because most of you ask a lot about that and wants to visit. So anytime you are welcome to visit this place, of course. Let's see. Okay, can I start? Thank you. This is the Wonder Shop, an intimate boutique, a special place, a calm, safe room where you can ask questions, talk openly, and explore solutions. This boutique was created for people affected by gynecological or breast cancer and for their loved ones. It's a space for relearning intimacy, for reconnecting body and soul. As a result of treatment, vaginal narrowing is common, which can make even medical examinations difficult. This may be accompanied by decreased libido, lymphedema, or the effect of menopause, all of which impact quality of life. Ideally, the issue is first assessed by a doctor, a gynecologist, surgical oncologist, or oncologist at the hospital, and then the patient visits us. During the consultation, we take time to listen to your story. We introduce helpful tools, talk about lubrication and desire support, openly without taboos in a safe and accepting space. You are welcome to come alone or with someone. It's entirely up to you who you invite into this intimate conversation. If needed, our psychologists are also available for emotional or relationship support. The Wonder Shop is at the heart of the Mallow Flower Foundation, but it speaks to everyone who wants to rediscover closeness, touch, or is simply searching for the right support. Feel free to reach out to us with trust. So in the safety place, we can start our webinar. Just before that, we are really grateful to our partners for their support. So without them, this conversation would not have been possible. Open dialogue about sexual health is more important today than ever before. It's encouraging to see that quality of life truly matters. So I really want to thank you in the name of ENAGAGE for Genmab and Pharma and the support. And we would like to give them these virtual flowers because of the support of quality of life of gynecological cancer patients. So thank you so much. And now it's my pleasure to introduce Professor Dr. Katrin Kirchner, Associate Professor and Clinical Psychologist at the Department of Radiation Oncology at the Medical University of Vienna. Her research focuses on psycho-oncology with special emphasis on quality of life and sexual health after gynecological cancers. She is a leading expert in the EMBRACE studies, which have shaped our understanding of vaginal morbidity and sexual well-being following chemoradiation and brachytherapy in cervical cancer. Her work brings critical insights into both the physical and psychological aspects of survivorship, making her a key voice in this field. Thank you, Katrin. The floor is yours.
Thank you very much, Itsu, for these kind words of introduction and also for inviting me to participate in this workshop this evening. So my topic today is the intimacy in the shadow of chronic illness, sexuality, but also quality of life in our gynecological cancer survivors. And of course, if we look at any part of sexual health after, oops, that's a bit too fast, after gynae cancer and also after the treatment, no matter if it's surgery, radiation oncology, chemotherapy, immunotherapy, we always have a very individual and complex interplay between physiological changes, so changes in the body on the one hand, but also relationship changes, interpersonal changes on relationship dynamics, communication in the couple, sexual scripts. And the big third part, of course, are also the psychological or mental changes that can result from the cancer diagnosis on the one hand, but also from treatment. So body image issues, problems with self-esteem, or all topics around femininity, the loss of fertility after treatment that can cause stress, it can cause trauma, anxiety, but also grief, of course. And also in honoring the Ovarian Cancer Day, I put even more complex layers underneath, because we know patients coming from a curative setting that are in complete remission long-term, but they have a very different situation from patients in a chronic setting with stable disease, but still with intermittent and repeated treatment. And those patients that are in a palliative setting with a progressive disease and all the transitions in between, because this has a huge impact, of course, also on the topics surrounding sexuality and sexual health. And you will see that it looks quite different. But let's start here in taking a look back, going even back to the time of the cancer diagnosis, the time during the first primary treatment and shortly after the treatment, about the recovery from the first primary side effects also, and taking this look back when the sexual recovery period substantially started. I sometimes tell my patient it's like a little plant, you know, your sexual recovery. You have to really keep it close, take good care, because at the time of diagnosis, with the cancer diagnosis, suddenly the body becomes site of a vital threat. It's rather this threat, the anxiety, rather than the body being a site of connection, of intimate connection. So the initial mental focus at the time of diagnosis is in the majority of patients to put survival first and survival over pleasure. And also during cancer treatment, the body becomes more or less an object to medical care. And being part of the medical team, we often don't like to hear this, but also the body is for a certain point in time under the control of the medical team. And treatment, cancer treatment, can cause a big violation in the physical integrity. And treatment can also sometimes be a traumatic experience. We have to acknowledge this. And it can lead to kind of an inner distancing of body sensations, the feeling of detachment, the feeling of alienation, and also some patients report a certain level of numbness, like my upper body is not connected to my lower body any longer. So in this phase, it's completely normal that sexual needs and also sexual interest remain mainly in the background, but the majority of patients still have a wish for physical closeness, for tenderness, and for intimacy. This often remains. But then also after treatment, after this primary treatment, in the phase of early recovery, it's like you count your stars. The acute side effects, they might heal, but still many patients are they have some burden of symptoms. Some of them have to endure pain. It's also a little this struggle to fight for recovery. You are in this active rehabilitation phase where everything needs to get newly sorted and reintegrated into daily routine and daily life habits. And there is, especially at the beginning, always this underlying fear of remission status. So this is also often a time where the sexual needs, the sexual interests are not really in the foreground. And over time, then you might start to evaluate, okay, what are the long-term consequences for me? What are long-term side effects? Can they be managed in a medical way? Can I develop some coping strategies? Can I adapt consequences of this treatment into my daily life? And to be super clear, cancer and the treatment can impact the sexual organs. Not in every patient, not to always the same degree, but those consequences can happen, they must not happen. Treatment can lead to changes in the vaginal anatomy. For example, reducing the length of the vagina or even the diameter of the vagina, so that intercourse might feel subjectively very different. You might feel even the vaginal shortening or tightening, or you might feel that the elasticity is less, and this can lead to discomfort or even pain during sexual intercourse. In several other patients, nerve damage or tissue damage is a topic which might have the consequence of reduced sensation, so to feel less, reduced blood flow, and therefore some problems with arousal or discomfort, or even to have a scar pain after surgery. There is overall a high probability to have a reduced blood flow in the whole pelvic area, but especially also in the vagina or in the clitoris. And this makes these organs less sensitive for sexual stimulation. Sexual arousal might need significantly longer. It needs more time, sometimes even a different kind of stimulation. And in general, the time to orgasm can also increase. Other changes are the thinning of the vaginal lining that you can see here on this picture on the right side. This is called atrophy, that can lead to irritation or itching, burning, reduced lubrication despite sexual arousal, so problems to get wet. And of course, a dry friction during intercourse might result in pain. And the whole vaginal lining can become fragile, and this can lead to contact bleeding during intercourse. But also, there might be changes in the vaginal microbiome that increase the risk for bacterial infection or yeast infection. And one of the big underlying factors with high impact also on your well-being are the changes in the sex hormones, the changes in estrogen, progesterone, and testosterone that might lead to a reduction of libido, of sexual desire, and might also change your sexual response cycle. But looking on the other side, of course, treatment can have an effect on your body image. Treatment can leave some physical marks that can change the way you see yourself and you feel about your appearance in your body. That might be scars after surgery or weight changes. Other patients have a lymphedema with high impact on body image, even a loss of body parts or stoma or changes in the hair and the skin. And this can lead to avoidance to show yourself, to expose your body, and also in some patients to shame. So the leading question here in therapy are, can I look in the mirror and truly see myself? Can I look at myself naked and even give myself a big hug and embrace myself? Can I touch all parts of my body? How does it feel now? What has changed? And I think the most basic question in therapy is, do I feel at home in this body now? And lots of patients tell me that they are especially afraid that the partner has some feeling of rejection or even disgust. So the questions are, am I still attractive to my partner? Am I still desirable if I don't feel so well inside my body? How does my partner think about my body now? Other issues surround topics of self-confidence, self-worth even. So who am I now after surviving this battle? How do I define myself? What is my role now in family, in my job, in life? Being a lover, being a friend, being a parent. So what does femininity mean to me? And how do I handle this loss of fertility here? And the fourth big part are issues that are related to traumatic experiences caused by the cancer itself, but also by treatment that lead to this inner distancing and disconnection to the body. So here I would, as a therapist, ask the question, can you connect with all parts of your body? Do you feel all parts of your body? Can you allow yourself to fully relax? Can you connect to all of your senses even? And can you enjoy some sensuality and also some pleasure, leading you through this trauma and the effects on body image? So what is helpful? One of the most helpful tools in dealing with body image is emotional touch. This can be really healing. In emotional touch, you see, I put some examples down here. They are all collected from my patients. Emotional touch are very small gestures of physical intimacy, but without the sexual background and also importantly, without sexual expectations. And they are those small gestures that restore dignity and also the relational meaning between you and your partner. So emotional touch do strongly affirm aliveness, but also connection and acceptance here. And the majority of my patients after primary treatment, if they come for counseling, they tell me, okay, now I'm back, now everything goes back to normality. And also in my sex life, I want everything that it is how it was before. And there lies a big potential for disappointment. And I have to share some really hard facts with you. As Itzo mentioned already in her introduction, we made a survey on sexual health 22 and had some big feedback coming from the community with over 600 cervical and ovarian cancer survivors. And unfortunately, nearly 60% of those cancer survivors told that their sex life changed to the worse after cancer diagnosis and treatment, and that 24% stated that they are not sexually active any longer. And also asking for satisfaction with their sexual health overall, nearly 60% were somehow dissatisfied or very dissatisfied with their sexual health. So just looking to those patients, 24% who said, I'm not sexually active any longer, we also have to acknowledge this openly. For some cancer survivors, sexuality might simply come to an end. And there is no shame about this. And this is okay and needs to be respected. In some patients, it's not due to any dysfunction, because for some women, it's just no longer a personal priority. They do not enjoy sex. They do not want sex. Absolutely okay. What matters in these cases is just clarity, knowing the boundaries, but also communicating them with compassion, also to the partner. Relationships can remain strong, they can remain intimate and also deeply connected, even without sexual activity. There is no moral obligation to return to sexual activity. And also sometimes society creates a lot of pressure that we all want our patients to be sexually active and healthy. And in some cases, letting go of those expectations might also bring relief and authenticity to the partnership. So I just also want to acknowledge this here. But the other patients, how to establish this new normal? You know, there are 3 big building blocks I would like to quickly guide you through that work pretty well, how to rediscover sexual activities together. As I said before, sexual life in the majority of cases will be not as it was before. There needs to be a new normal. And if we look at the first step here, I wrote changing of sexual scripts. So what are sexual scripts? Sexual scripts are the familiar pattern or the routine that long-term partners created during intimate moments. So the ritual that are established between you and your partner, how you initiate intimacy, how sexual arousal builds, and how also sexual closeness unfolds then. This is very much shaped by your personal history, but also the preferences, what you like, what you don't like, and mutual habits. This gives a sense of structure, but also of safety during sexual interactions. And I like to think about sexual script like the dance with a familiar partner. You have your shared rhythm, you have this natural flow, you are at ease, and this allows to make some dance variations then within the boundaries that you know. But after, or let's stay with an example, a very individual, just an example of a heterosexual sexual script here. So in this example, in this heterosexual couple, they initiated sexual intimacy always with hugging. And then they started kissing as the next step in this sequence. And then they were completely aware they will undress each other. And then intimate touching will follow, intercourse will follow, leading to orgasm. Yes, script is fulfilled. So one specific sequence, one follows the other. So of course now, if you are after this cancer treatment or as a cancer survivor, if you are not up to intercourse and orgasm and you don't feel for it, your immediate reaction will be, oh my God, my partner hugs me. No, 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 I don't want this because I have the expectation to follow the script and I'm not ready for that. So expectations create pressure. And in sexual therapy, we will always interrupt this sexual script here. And to make it very clear, sex is not a yes or no activity. So that you have either to take the complete package, including intercourse, or to reject any physical closeness and intimacy from the very beginning, just to avoid to set up wrong expectations in the partner. So if we work to establish a new normal, this needs a lot of flexibility and also creativity. But most important is always keep the physical closeness and intimacy. This does not mean intercourse. break the script and cancel all expectations that create so much pressure and that are usually so scared. So instead of saying, no, 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 I don't want this, I'm not going to follow with this sexual script here, it's more to work on, okay, but I don't want this, but what do I want? What actually feels good? What brings us pleasure together? And to create the list here together with your partner and to bring those parts together. But keep in mind, and this is for me as a psychologist really important, you might have some impact on your interest in libido, and this is physiologically. This is not your fault. You are not broken in any way. This might be a consequence of treatment that you have low libido. It might also be a consequence that you need a complete different approach, how to initiate intimacy and how to follow seduction. It might take much more time for arousal than before. It might take different stimulation for your sexual pleasure. Things that worked before might not work any longer, but you have to find out what works for you. And it also might take some supportive aids or devices for sexual comfort and for sexual enjoyment. And this is what you saw in this beautiful little movie from ESGO, the whole overview of the sexual devices that might be helpful in here. And you can imagine for all of these changes in sexual script, communication is key. You need to talk with your partner explicitly about your sexual scripts. So here also some leading questions. How do we name all those activities in our relationships? Do we have some specific terms? How can I announce some sexual wishes and some needs and also some boundaries without hurting my partner or even that my partner feels criticized by this? And sometimes I hear this quite often from male partners specifically. Oh my God, all this talking, it completely ruins the erotic spirits. Everything has to be spontaneous and we cannot talk about this, you know? And one big part in sexual therapy is to discuss sexual communication can be incorporated even as erotic component. It can be even quite sexy to talk about needs, wishes, and boundaries. So how can we establish a pillow talk as part of the mental foreplay? There are some very dysfunctional assumptions in many relationships that I witnessed, some misconceptions that it's better to be silent about it and avoid this difficult topic. So I heard, oh my God, talking about sexual problems, it only makes things worse. I also heard, we should just be grateful to be alive and together, nothing beyond. If it can't be changed, there is no point in talking about how bad it is. Or if it's really a problem, he or she will speak up eventually. Or even one very dysfunctional assumption, the sexual topic, this will resolve itself over time. And I can tell you from clinical experience, no, it does not resolve, just without working on it and without communicating about this. The cost of silence, the price for this silence is quite high. So what happens if we don't talk, and you will hear this also from Stephanie in the next talk, this kind of protective silence just builds emotional distance, conflicting underlying assumptions and a big room for misunderstandings. So this it also leads to increased loneliness and isolation, and there is often a misinterpretation if you avoid physical contact that this is a lack of love or affection. It can create feelings of guilt. It can make a lot of pressure, even resentment in the background. And partners may turn to secrecy, self-isolation, or simply silent suffering. And this leads to mistrust and withdrawal in the relationship. So this is all a big cause for disconnection. Now looking and also acknowledging, especially today on the ovarian cancer day, the very different clinical context of patients who are in a chronic phase of disease. So the disease is stable, but there are still different intermittent treatment. This is so very different compared to patients who are in long-term complete remissions and do regard themselves as cured, right? So in a chronic phase, there is the need for constant adaptation to different treatments. It's also a different issue to deal with uncertainty of the disease, and there are high demands on physical and also mental coping strategies that need so much more flexibility. Just think of the time at the cancer diagnosis and treatment, you know, how much burden this is. In chronic patients, chronic cancer patients, this might just be on a loop, on repeat. So the challenges are a certain fluctuation of symptoms and also side effects from treatment that may lead to an ongoing insecurity in erotic exposure. Patients might feel a little bit in between. I'm neither entirely healthy and I'm also not completely ill, but I'm somewhere fluctuating in between. And also the struggle of feeling desirable. One question that is often asked, am I still lovable now? Am I still desired by my partner? Can I still feel as a whole woman? And also this fluctuation, and there are some good days and there are worse days due to the treatment cycles that might also lead to long breaks between sexual activities, and they are very normal. Many patients are extremely frustrated because they lose the spontaneity and the effortlessness of sex. Just to say, hey, tonight I really feel it, you know, this spontaneous encounters, because this treatment will lead to some kind of unpredictability here. And even planning sexual intimacy might seem really, really difficult, sometimes even impossible, and then further leading to avoidance. And there is also a certain ambivalence here. Some patients say, listen, I really want to get back my sexual health now. It's a sign of vitality and of being alive. But simultaneously, I cannot feel it. I have a complete lack of erotic energy. I'm just tired of this. And this ambivalence, this can even create some pressure to sexually perform, or even a feeling of shame if this fails to take place here. And now I move into really difficult and extremely sensitive part, into the palliative and progressive phase of disease. So the clinical context is that the disease progresses, it becomes very evident, curative treatment comes to an end, there is an increasing physical decline, symptoms go up, and the patient has increasing care needs. So just to remember, physical touch, any kind of physical touch in this palliative phase is mostly in the caregiving, in a professional context. It's very functional. Patients suffer from a loss of their bodily autonomy and also a loss of privacy. You know, catheters are, urine catheters are used, sometimes even diapers are used. Infusions are set up, oxygen is set up. So this is also really a loss of control over their own body and a very deep loss of privacy that can lead to detachment. And just to consider also the role of the partner here. The partner of a palliative patient is the role of a caregiver, but also the role as a witness and a companion in grief. And the partner has to balance deep empathy on the one hand and deep grief and suffering, but also on the other hand, the own emotional needs and also the bodily needs. And to be very frank and honest here, the word pleasure even is in many cases far, far out of reach. So if we do talk about sexual health in palliative cancer patients, It means the need for non-sexual intimacy. So the need for touch, not so much for pleasure, but the touch for safety, for dignity, and the touch for connection. So what can this be? The warmth of a hug, the deep eye contact, a very gentle and affectionate touch, the simple fact of breathing together, being skin on skin together. Because patients tell me in therapy, they are really afraid to be seen as untouchable now, or too fragile, or even broken. So the leading question is here, will my partner still see me as a person, or will my partner only see the illness now? There is a big longing for closeness that affirms life, not just the illness, not just the hard facts in this palliative phase here. So for me, as a psychologist, leading you through this just a little bit, for me it means we really have to rethink the meaning of sexuality on a very deep level, not only in the frame of disease or in the frame of palliative care, but even beyond. Sexuality represents so much more than sexual intercourse, right? So if we do talk about sex on a very casual level, we all think about sexual intercourse. But I think in this, we really have to open this big frame, what sexuality can mean. You know? Connection, sensuality, tenderness, intimacy, also pleasure, but also not sometimes. But for sure, it's a big sign for emotional closeness. And with this picture and this broad message, I would like to thank you very much for your attention on this. And I'm very happy to answer also your questions in the chat and later in the QA.
Thank you so much, Catherine. It is always very nice to listen to you. And I have a lot in my mind, of course, and we usually discuss a lot, which I appreciate very much. And yes, we have to accept new normal, and that new normal is also changing, right? Especially when there is a chronic disease and illness. We have very nice comments and questions in the Q&A box. And after the talks, we can a little bit see these and maybe touch some of them. So now please welcome Dr. Stephanie Christodoulidou. She is a dedicated psychologist, psychotherapist, and a patient advocate with extensive experience in psycho-oncology and teaching. She serves as a head of psychosocial services for Europe Donna, Cyprus, providing psychological support to breast cancer and gynae cancer patients and their families, and as a university lecturer specializing in counseling psychology and communication skills in medicine. Stephanie, you are the next one.
Thank you very much, Icha, for the introduction, and thank you, Catherine, for the excellent presentation, and thank you, everybody, for being here tonight. Let me share my presentation to see if it's working.
Perfect.
Can you see my screen?
Yes, we can see that.
Okay, great. Thank you. So welcome, everyone. Thank you for being here. It's really good to be here too on this very special day, World Ovarian Cancer Day. So today's subject, I think it often gets left in the shadows, and sexual health in the context of gynecological cancer is rarely discussed because it's emotional, it's physical, it's relational, and yes, very deeply human. And that's why we need to talk about it more. So whether you're a healthcare provider, a patient, or a partner, you probably already know this, that the conversation in this space can get very complicated. I'm a psychologist, which means I spend a lot of time asking uncomfortable questions, and I spend a lot of time asking people how they feel. But today I would like to take the opportunity to zoom out, and I want to talk about all of us, patients, doctors, partners, how we talk to each other, what helps, what hurts, what makes things awkward, and what makes things healing. Because in gynecological cancer, communication is not just an add-on, it's treatment. And when it breaks down, we all feel it, emotionally, relationally, and sometimes even physically. So communication can either relieve or intensify the emotional weight of a diagnosis. So let's talk about sex. Has my slide changed? No.
No, you have to point in,
Y-
and then you can, I think, change.
mm,
Try now. Yes, now it's
Okay, great. Okay. I'm not very good with this, obviously. So, sexual health is something that is often left unsaid, but it's deeply felt. So it's not just about sex, as Catherine mentioned earlier, but it's about body image, it's about intimacy, it's about connection, and how patients, partners, and providers can build bridges back to one another. And in my career as a psychologist, I've sat with many women grieving not only their health, but their sense of identity, their sense of desire, and closeness with loved ones. So let's explore how communication can help heal some of these quiet wounds. So, why is it so hard to talk about sex? In reality, we all do it. And it's part of our lives. So I think there are many reasons why sexual health is rarely discussed, and I think patients might feel embarrassed or ashamed. Doctors may prioritize treatment protocols over quality of life conversations, and partners might not know how to bring it up without sounding selfish or inappropriate. And sexual health is often left out of the conversation because of these reasons. Survival becomes the goal, understandably, but sexuality is part of the survivorship. And many clinicians aren't trained to talk about these issues. So talking about these issues makes them feel very uncomfortable. Patients in turn feel too embarrassed or fear it's not the right time to ask about sex. And in this lies a silent message. This part of you doesn't matter anymore. But thank God we're here today to challenge that. So what changes after diagnosis? A lot of things change. The impact of gynecological cancer on the body and the mind, it lies on many facets. There are the physical changes, as mentioned earlier. There are hormonal disruptions. There are neurological aspects that might be involved. The psychological responses, such as depression or anxiety, PTSD, or body dysmorphia. And there's, of course, the relational effects, the impact on intimacy, on communication with our partner, the fear of rejection. And gynecological cancer often leads to changes in body function and in our sense of identity, and that there's a fear of no longer being desirable by our partner. And all of that can make intimacy very, very difficult and even frightening sometimes. But let's be real, talking about gynecological cancer is not like chatting about the weather. So there are emotional landmines of communication during cancer. Patients often share with me that I don't want to stress anyone out, I'll just keep it to myself. They hold back and avoid burdening others, and they don't express their questions or their emotions. On the other hand, medical language can be very overwhelming. Terms we don't fully understand but are too anxious or embarrassed to ask about them. Doctors, meanwhile, and I sympathize for them, are juggling time, science, and their own humanity. And then we get to the stuff no one wants to mention: sex, body image, fertility, and so on. So talking about gynecological parts can be, in some cultures, very difficult. So sensitive issues like sexuality, fertility, or bodily changes are often surrounded by taboos, stigma, silence, even though they are central to a woman's sense of self. Partners often feel left out or unsure of their role. They want to help, but they don't know how to participate in such conversations that seem dominated by medical details. So these are very natural, but also very addressable barriers. And what I want us to keep from this discussion is to recognize that recognizing these barriers is the first step towards overcoming them. Moving on. Just a few points on this triangle, the communication triangle. Communication in this space can be seen as a triangle. The triangle represents the communication system surrounding the patient. Each point, the patient, the doctor, and the partner has unique needs and emotions. And when any side of this triangle is disconnected, misunderstandings can quickly grow. If one point goes silent, the whole system is affected. So, for example, the patient may hesitate to bring up concerns. The partner then may withdraw out of fear or guilt. The doctor might avoid it entirely. So we need all three parties actively engaged for the relationship and for healing to continue and to stay strong. So communication is not a line, it's a system. So each point of the triangle matters. When one connection breaks down, communication fails. We need to connect all sides, patient to doctor, patient to partner, doctor to partner, partner to doctor for a strong support system. And I mean, this is not just theory, it's what we hear every day in our therapy rooms. And I think Catherine can confirm that. So let's take a real life scenario. Let's imagine a real, very common situation. A woman receives a diagnosis of advanced ovarian cancer. During the consultation, her doctor gives her a detailed account of what's going on, but she doesn't say a word. She just nods. Afterward, she tells her partner, I have no idea what he said, but she doesn't want to call the doctor again. She doesn't want to burden the doctor. Her partner feels frustrated. Unsure how to help. Should I call the doctor myself and ask the questions? Should I just leave her in peace? The doctor, meanwhile, thinks that the conversation went great because there were no questions. But apparently, this is a breakdown, not of competence, but of connection. But it's preventable. So let's assume, what if the doctor had asked, can I pause here? How does all this feel emotionally? Or if the partner had been invited to ask his or her own questions. So small shifts like this can rebuild the triangle. So let's avoid making assumptions to keep the communication bridge intact. And the silence trap, where everyone tries to protect each other by staying silent. But silence feeds shame, it feeds uncertainty, it feeds the fear, and it feeds isolation. So we must normalize conversations about sex as part of cancer care and not apart from it. So I've just I've chosen a few quotes that I've heard from patients telling me when they come to therapy, like, will I ever feel like myself again? Why didn't anyone warn me about this? I miss the closeness. Will I still be attractive? Is it safe to have sex? Do other women have similar concerns? So patients carry these unspoken fears. Many feel ashamed or worried that their needs are not important right now. Some people feel that they don't want to be a burden for their doctor or their partners. Others think they're the only one feeling this way. I remember one woman saying to me, I wanted someone to tell me that it was okay to want intimacy. I didn't want to bring it up first. And I think sometimes patients are not just seeking for answers, they want validation that what they're going through matters, and they want to know that they're not alone in this, that their fears are legitimate, that pleasure and connection aren't off the table, that instead they might just need a new menu. And on the other hand, we have the partners that often think about things which they don't speak about. I don't want to hurt her. I miss our connection, but I don't want to pressure her. I'm scared of rejection or of saying the wrong things. How do I talk about this without sounding selfish? So partners are very concerned about doing the right things or saying the right things. So usually they opt to stay quiet, but this creates emotional distance. But we need to recognize that they too are grieving, and many don't know if affection is welcome anymore or how to help without making things worse. We must support them too, and their silence often hides deep love and confusion as well. So what do we all need from the three parts of the triangle? From the patient's perspective, I think they need clarity, but also kindness. They need honesty, a space to ask questions. They need room for uncertainty and space to bring emotions into the room, not just symptoms. Doctors, on the other hand, face pressure, as we mentioned earlier, and they may not know whether to explore personal issues or to keep it to medical facts. So doctors need cooperation and a chance to connect on a human level. But building trust often requires slowing down a little bit or asking a question like, how are you coping emotionally? And partners often feel unsure where they fit, including them when the patient is, of course, comfortable with it, can provide a shared language for what's happening. Partners want to help, but they also want to feel included and emotionally acknowledged. So everyone is navigating vulnerability in a very different way. So moving on to the communication tips. There are a few actionable everyday tips for each member of the triangle. None of this, I think, requires more time. It just needs more intention and more effort, and it can change a lot of things. So doctors, we can replace any questions with what's unclear. We can try open-ended question like, what's your biggest concern today? And I think one of the most important things is to normalize sensitive topics, such as many women wonder about intimacy. Would it help to talk about that? And I always tell my patients to go to their doctors prepared. Go with your list, go with your notepads, ask questions. You can ask them the same question even 10, 20 times if you want that. Repetition is fine. Let yourself bring up fears, not just physical symptoms. You're not a burden. You are more than what's happened to your body. Communicate openly. Give yourself permission to grieve and to heal. And it's okay to mourn changes, and it's okay to still want joy, pleasure, and connection. Talking is healing. Asking for help is brave. So go out there and seek support. And partners, you can ask, do you want help or do you just want me to be present? Your role is so important. It matters and it does not have to be perfect. You have to communicate your own needs as well. And it's very good to separate intimacy from performance and explore new forms of closeness, like Catherine said earlier. And very quickly, for health, this is for healthcare professionals. Inclusive, respectful language is always very helpful. We should normalize discomfort but encourage openness. Humor is always welcome, and if used appropriately, can diffuse tension. Handouts, diagrams, checklists can help people explore these difficult topic privately later. And we can check the understanding of patients by asking them to repeat what they heard in their own words and acknowledging and naming emotions. It's okay to feel scared and confused. And take some time to create check-in moments during consultation. One small comment from the doctor can change everything. We don't need to have all the answers, just openness, validation, and a very good referral network. And that's good enough healing in itself. So, beyond assumptions and diverse sexualities and preconceptions, another vital layer to this conversation is the diversity of sexualities and identities. Not every patient is heterosexual or partner. And these identities shape how cancer affects sexuality and intimacy. Unfortunately, sometimes even well-meaning clinicians may assume that a patient is straight, monogamous, or has a male partner. This can make patients feel invisible or unsafe. Instead of using husband, we can use the word partner. Ask what terms they use for their body or their sexuality, and never assume someone's relationship status or sexual preferences. Inclusive care is not just about being politically correct. It's about seeing the whole person and letting them know that they are heard and understood and included. And going to the difficult parts, when intimacy ends and managing a breakup after gynecological cancer. And in my experience, cancer can bring couples very close to each other, or it can break them apart. So sometimes, despite best efforts, relationships don't survive the strain of cancer. And breakups after treatment can feel like a second loss, not just of a partner, but of stability, of identity, of even hope. So many patients ask me, was it me? Was it my body? Was it the changes in my body, my scars? Was it my sadness? So they tend to blame themselves. But often the relationship was already strained. Cancer just revealed the cracks. And healing after a breakup means tending to grief, but also relearning how to feel worthy, how to feel lovable and whole, sexually and emotionally. And let's remember that intimacy can still exist with ourselves, with new connection, and with life itself. So going back to the dating scene, dating again and starting a new relationship after gynecological cancer. It can feel very daunting. Like carrying a secret that you're not sure how and when to share it. So patients over ask me, how do I explain the changes to my body? Or how do I communicate my sexual needs? Or how do I tell my story? So it's important to keep in mind that it's okay to go slow. You don't owe your whole story on the first date. So when you do share, it's going to be a story of your strength. You've been through something profound and you're still very open to connection, and that's strength. So entering a new relationship isn't just about the logistics and the practical part, but it's also being emotionally ready for it. So you may feel vulnerable, cautious, unsure how to bring up this cancer story, but there's no script. You can share when trust begins to form, and framing your experience as a source of your own resilience. This can create a very powerful connection between you and your partner. So many survivors worry about these changes, and that's completely valid. But intimacy is about more than appearance or performance. It's about feeling safe, it's about feeling seen, and it's about feeling accepted. So you don't have to rush into physical closeness. Build it at your own pace. And the right person will see your courage, you'll see your story, and they'll have the capacity to love you. So I think in therapy, it's a subject that we often discuss, and we can together we can prepare such conversations. And remember that it's not about returning to our old self. It's about discovering the new you in the company of together with your therapist. So as Catherine mentioned earlier, intimacy might look different after a cancer diagnosis, but that doesn't mean that it's less real. So some couples discover deeper connections in slowness, mutual care, and emotional vulnerability. So redefining intimacy creates new paths forward, and apart from the practical options that someone might have, there are so many things that we can offer in support of patients, such as sex therapy, pelvic floor therapy, and these tools should become a routine, a routine for healthcare professionals to prescribe them to patients. And resources exist and work. So also another huge topic that maybe we can discuss into greater detail some other time is rebuilding confidence. And as I mentioned before, it's not about going back, it's about moving forward differently. And women can reconnect with their bodies slowly through breathing, through touching, through dancing, whatever feels right in your own skin. And confidence doesn't come from being the same, it comes from feeling seen and feeling loved in your now body. So sexuality should not be a side issue. It's part of quality of life, of dignity, of human nature. So reclaiming it is not selfish, it's healing. So when we talk about sex and intimacy, we talk about life, fully, honestly, and bravely. So this conversation is not a side note, it's part and should be a part of holistic cancer care. So sexuality is part of our own identity, our emotional survival, our quality of life. So let's create space for it with kindness, with honesty, and with curiosity. So communication cannot change the diagnosis, but it changes how we live with it. And let's not aim for perfect words, let's aim for honest ones. So communication is more than words, it's connection, it's caring. And sometimes what the patient needs most is not a brilliant answer, but a listening heart. So as a psychologist, I don't just listen to what people say, I try to listen to what people are afraid to say. So when we open the space for a most honest human communication between patient, doctor, and partner, we don't just treat the disease, we treat fear, we treat loneliness, and we also invite resilience. So I will leave you today with two quotes that I found and I really loved. The most important thing in communication is hearing what isn't said. And what we say matters, but what we hear matters even more. So thank you for your time. I would gladly ask any questions, any reflections, or anybody wants to share a story. This is more than welcome. And thank you once again, ENAGAGE, for the invitation.
Thank you so much, Stephanie. Today I had a lecture about ovarian cancer at a company, and at the end, a doctor said that say it loud that your partner is beautiful. It gives a lot to her. It means a lot, and it gives back, of course. And we can show our love because love is the main component of everything. So when we talk about sexuality, we talk about communication, partnership, survivorship. Love is always there. So it's the main component. So thank you so much, this excellent talk.
Yeah.
And now let me introduce you Dr. Richard Toth, a gynae surgeon of Semmelweis University, Department of Obstetrics and Gynecology in Budapest. As a dedicated person specializing in gynecological oncology, Dr. Toth is an active member of the European Network of Gynae Oncologists. He's also honorary member of the Mellowflower Foundation, and he is the national lead of the NOPREM study in Hungary, focusing on rehabilitation in gynecological cancers. He's also deeply committed to improving patients' quality of life, including work on sexual rehabilitation. So let's hear the cases, Richard.
Okay, so thank you very much for the invitation, and thank you for the fantastic presentations, both of you, Catherine and Stephanie. It was really, really good to hear those, and it was very practical. So I just brought some cases I would like to share you. Can you see it in the slides?
Yes.
Okay.
Yes, yes, we can.
Okay, thank you. So and the first case would be quite. Oh, sorry. Did I?
We can see I think a 60 years old lady,
Yeah.
right?
Okay. No, just I missed something. So it's like
We can see that.
you can see that. So great. So I just missed it for myself.
You can't. That's tricky.
Sorry for just for that.
Maybe you have to stop and share it again.
Yeah. Probably that would be the best thing to. But I can't. Okay. Sorry for that.
It's okay.
Okay, now. So, is it okay now? Yeah.
Yep, we can
So
see.
this is a case of a 60-year-old patient who was diagnosed with endometrial cancer. She was operated via laparoscopy. She received a hysterectomy, sapping of rectum on both sides, and lymphadenectomy with sentinel lymph nodes. And then finally we received the staging for stage 2 low-grade endometrial cancer without any lymph node involvement. But there was unaffected vaginal cough. For that reason, we decided to administer her brachytherapy. It was quite easy with her because she was quite open for sexual questions. She started with this sentence that sexual life is a really important part of their life with her husband, and she doesn't want anything to be changed. She would like to maintain this perfectness that they have in their sexual life. But unfortunately, after the operation and the brachytherapy, she lost the lubrication. She had some vaginal tightening and some vaginal shortening. So it was quite sad to speak about sexual health issues afterwards, because she told us this story, and she was we felt like she's quite grieving the loss of her former sexual life. So I would like to ask you both, Stephanie and Katrin, how would you proceed? What would you do? How to go forward with the building up the communication with her, or how would you do that?
Maybe I can start with this case coming also from problems surrounding radiation. So the vaginal tightening and shortening that can be felt, that's quite a common side effect from brachytherapy. And to a certain extent, this patient can counteract a little bit in applying vaginal moisturizers and dilate the vagina to keep a little bit elasticity. But for me, I think this case from a psychological point of view is more about giving the room to grieve. As Stephanie told so beautifully in words, give her the space to grieve and to also let go from the old and very perfect or effortless way she enjoyed intercourse with her husband. Sometimes we tend in clinical practice to rush patients to come to this new normal or discover their new self. And I think this patient needs really time to grieve, and then later on a lot of help how to deal with this vaginal stenosis and lack of lubrication during intercourse, because there are a lot of supportive aids and tools that can help also dealing with discomfort and pain. So first, using lubricants, because if this patient cannot get wet from arousal, she needs artificial lubricant. And second, also the vaginal tightening and shortening can also be counteracted a bit in using pain buffers, so silicone rings that can be put on the shaft of the penis in order to reduce the depth of penetration. So there are a lot of small things to support this patient, but I think firstly, she needs some space to grieve. Stephanie.
I completely agree with you, Catherine. I am on the same page. And there are stages to grief. So a person needs time to go through these stages and grieve all the losses that come after a cancer diagnosis. And perhaps one thing that I would do with the patient is to try and make a psychological priority checklist of what is the main concern and try and explore that further. And after the grieving period will ends, then it's the period where somebody has the chance to redefine both the sense of self, the sense of identity, and the sense of sexuality. So I think space would be the great, but not too much space where the other person feels alone. We can be next to the person, next to our partner, by giving them enough space.
For me, just one question. So when do you think we should refer these patients to sexual therapist? Because we can give some advices by ourselves. But when do you think it needs some more professional approach to overcome with the grief? Because I think it's not just a simple grief. It should have to be addressed by someone who's a psychologist who's specialized in sexual health as well. So what do you think about it? What is the normal limit? So do we have to think about it like a normal grief, normal process? So is there a time limit for that?
And I think after a cancer diagnosis, you have multiple losses to deal with. So preferably it would be a mental health professional who has experience in psycho-oncology, who has experience in this field, and to help the patient navigate through all these complicated losses. So my personal perspective is this.
For sure, for me, this sounds like a case where you could refer, and it would be very helpful to refer this patient. If you feel yourself this overwhelm of emotion and of grief, I think this is a very solid sign that this patient needs some extra psychosocial support here.
Thank you. So I would like to move on to our second case. It's a case of a young lady who is 31-year-old. She went to a routine checkup for gynecological examination where they found a bleeding mass in the cervix surface. They performed a biopsy, which confirmed squamous cell cancer grade 3 one. It was a localized disease, but quite big. Where she went first, they performed robotic lymphadenectomy and leukoconization to see what is the staging and whether there is any kind of option to perform a fertility sparing surgery. And finally, she received an abdominal radical trachelectomy. So in the final histology, we found that there were no residual disease after the colonization. But since the operation, she had some problems. There were inguinal numbness, and she felt this numbness in the left thigh as well. She developed a left like lymphedema. Since then, she has amenorrhea. She complains about stabbing-like pain at the vaginal fornix and some diffuse lower abdominal pain. So those are the physical issues. And when I asked her what about sex and what about her sexual life as she lives in a partnership now, and she said that although she had trachelectomy, she changed her mind and she don't want children anymore. So this is one really interesting question for me, that why she changed her mind, because she really insisted on having or protecting her uterus to have children afterwards. And when we talked about sex, she said she don't have sex, penetrative sex at all, although their relationship is stronger than ever since her operation. So it was quite strange for me, because when she said that, it was she felt me to be a bit sad, and like she's not telling the truth, although I can't decide whether it was the truth or not. But it was really a strange situation. So it's really hard to think about it, why she changed her mind after the cancer care, and then she got into a really bad sexual life situation. Or I can assume it's bad. Perhaps for her it's fine.
Richard, I think this is very simple to answer. We don't know why she changed her mind without asking her.
Yeah.
We should not make assumptions. We should simply ask the patient. And as you summarized it here, this was quite strange. I don't understand. I think it's exactly the thing to address with the patient. Can you explain further? Because I don't understand it now. What has changed? Right? So I cannot make assumption on this patient if she's happy with the absence of sex. What is sex? Does she mean intercourse? Does she mean intimacy? Does she mean all creative forms in between? I don't know. So for me, this would be clearly a case to ask the patient, to be honest. But Stephanie, maybe you are you have more ideas than me here.
Well, I can start making assumptions, but I think it wouldn't be the right thing to do. But it's worth exploring. It's definitely worth exploring. I think from trying to understand what's going on, or whether there are any emotions behind it, or any fears behind it, any concerns, it's something worthwhile. I think you could understand a lot in terms of how she perceives herself, and what made her change her mind. So I think it needs further exploration. Definitely.
Okay. Third case I would like to show you is a lady who's 60 years old. She had melanoma in her history, and she had a recurring bleeding disorder afterwards. She had a negative transvaginal ultrasound and negative pap test, and she received DNC because of the postmenopausal bleeding, and there was a suspect lesion in the ultrasound afterwards as well. So we performed a deep excision of the cervix, and we found that she has an HPV-associated squamous cell cancer. She was operable, so she received type C2 radical hysterectomy, and afterwards she needed no further treatment. But it was really hard for me to go into this conversation with her, and perhaps it's rather I would like to address this question to you, Stephanie, because when I asked her what about sex, she told that she just can't talk about it because she had only one partner during the last 40 years, and she just can't think about it. Perhaps it is the sign of cheating her on, and to assuming that her husband is responsible for all the nightmare she is going through. So it was really hard conversation, and it was really hard to close it, because of course we can talk about it, that it's fine. Perhaps she got the HPV thousands of years ago, but there are still the assumptions, and there's a loss of the connection that used to be strong between them, or at least she says it used to be strong. So how can I get out of this conversation fine without causing any harm?
I think it sounds like a very painful conversation. If she does have this belief, it must be very painful for her, and it must feel like a betrayal. But I think it would be worth suggesting for her and her partner to see a couples therapist as well, because it would be helpful for their relationship. I don't know if her belief it's something that can be confirmed, but it sounds very, very painful, and I think it's something that could be explored further in talking to a mental health professional. But I think it's a huge topic, and we hear about this a lot. Especially when HPV might be present.
Yeah.
Yes, I think the HPV as a also sexually transmitted virus carries now a lot of topics around guilt and shame and fidelity versus not, and also the questions who got infected first, who infected whom, in which constellation. How can this happen in 40 years of sexual exclusivity? What was the HPV test before that? You know, it's a different way because you cannot completely track it back.
Yeah.
So I think this patient has an assumption that is not completely, it must not be rooted, but this is of course in her head, and this is of course valid to talk it through with her. Absolutely. And yes, it is a nightmare also for you as a doctor.
I asked her whether she would like to go to a couple therapy, and she said no, she don't want to think about it, and she don't want to speak about it. Just let's bury it deep, and that's it. So it was really hard to open up this conversation as well.
Yes, I can imagine.
Not ready yet about it, I think.
Yeah, perhaps, yeah.
And I think there is a line we are not able to cross, right? So the help has its grains. So sometimes it's really difficult to push someone.
Yeah.
Thank you so much. This was the last one, right, Richard?
Yeah.
Regarding of the time, because it's really running so fast, I try to make some comments in the chat, and I would like to offer that now we don't read it and go to conversations, but we can take care of the questions, and after the webinar somehow with ENAGAGE, maybe on the social media or anything, we will figure out how to answer it. And there are some questions we really want to take care more, maybe next year with ENAGAGE, for example, the partner sides, which are also very important. So let me close the webinar, and I really would like to thank you for all. I'm very happy that we were together. You were all excellent, and I could continue for this webinar till the morning, I think, and listen to you. So I'm really happy that you are somehow part of ENAGAGE as well. And I'm sure that we will listen to you more in the future. So thank you so much, Catherine, Stephanie, and Richard.
Thank you. Have a nice evening.
Thank you.
And now we have a little more, just we have a Slido. So if we can see it on, thank you so much. So please use the QR code or join at slido.com and answer this question: that what message would you like to send to someone facing these challenges after gynecological cancer? This is just really the end of the webinar, and we are very excited to a little bit hear from you. Katerina put it into the chat too, so you can find it. So you can write more if you want. You can write one thing, but let us see your thoughts. We can see that you are writing. That's great. Okay, it's coming. Very nice.
Beautiful. Yeah.
Yeah, patient is very important also from both sides, of course, in sexuality and also healing. Time is not our friend till the treatments, but time is our friend after the treatments, right? Yeah, love yourself. Yes, that's also very important. Thank you so much. Explore your body again. Good. Observing forward, stopping, discover yourself. You are not alone.
This is beautiful.
Yes, it's very beautiful. Thank you. It's really nice to hear from you. Somehow hear from you, right? There were some comments and questions regarding when the woman is alone, there is no partner, and that is also an issue, of course. So I think we could talk a lot about these topics, and we will, I promise, in the future, step by step.
I want to highlight there is no normal. There is only what is right for you now. I think that's great.
Thank you so much. After the webinar, we really would like to hear from you about the webinar, the topics you really want to hear. So when you close it, then you will see a kind of questionnaire and you can send us your opinion. I love your new you. That's nice. That's really nice.
Yes.
It's quite late and you are here. That's
amazing.
An honor for us. Okay. It's coming. It's coming. More and more. Healing. Yeah, good. Lovable, yes. Okay, thank you so much. Have a great evening, late evening, and I hope we see you in October. So have a good night. Bye-bye.
Good night. Bye-bye. Thank you.
Good night.
Thank you. Thank you.